The following podcast is part of a certified educational activity titled Don't Miss Hidradenitis Suppurativa, providing timely diagnosis and management using novel agents. Access the entire activity and complete the post-test at peerview.com/TZU860. Downloadable slides and practice aids are also available.
Hello, I'm Jenny Shao, and I'm a dermatologist at the University of Southern California, where I run an HS specialty clinic. And thank you so much for joining this unique case-based educational activity titled Don't Miss the Diagnosis, Timely Identification of Hidradenitis Suppurativa and Management Using Novel Agents. Our goals for today's talk are to help improve your skills in recognizing and diagnosing HS quickly, equip you with the latest evidence surrounding new and emerging therapies for HS, of which there are many, and also to provide guidance on strategies to elevate your HS care to optimize patient outcomes. To start off the talk, I always think it's helpful to talk about why it's so imperative for us as clinicians to really do our best to treat these patients with HS. So many of them have suffered for so long with HS before they come to our doorstep. Many patients waiting 10 or more years just to know that they have a diagnosis of HS. We know that there's a disproportionate burden on female patients, on Black Americans. There's a really high disease burden overall, just with the impact on quality of life impairment, pain, drainage, disfigurement from HS. So many of these patients have depression and anxiety. Up until recently, we have been limited by our treatment options. We really relied on things like lifestyle changes or repeated antibiotic courses, surgeries. There was only one FDA-approved option, adalimumab, in 2015 for the longest time. Thankfully, we have two others now, IL-17 inhibitors, secukinumab and bimekizumab, so it's really exciting to be able to have more accessible treatment options for our patients. But for the longest time, we didn't have that much in our treatment arsenal, and I think that led to a lot of frustration, both for clinicians and patients alike. In addition, there was limited access to coordinated care. Many patients basically just kept going to the emergency room or urgent care for when they had their HS flares, given a week of antibiotics, and, maybe they had their abscess drained, and then it would just be back to the ER or urgent care the next time that it happened. And HS really is a condition that we want to be well managed in an outpatient derm clinic to avoid use of acute care settings. And finally, I think there's just been a lack of, sort of public knowledge about HS, also provider awareness. And hopefully this will change in upcoming years, as I feel like we've made a lot of progress in the last 10 years. And I'm just hoping for more and more as we get new therapies, and also as more HS awareness spreads, and patients themselves will come to seek us out because they heard about what HS is and they finally understand that that's what they have. So let's jump into diagnosing HS. So we wanted to start with a case study. So this is Jill. She is a 32-year-old woman, and she's presenting with painful abscesses and inflamed nodules in her axillary and buttock region. She's seen several specialists since her early 20s. She does get sort of pus and bloody discharge from her abscesses from time to time. When you see a patient like this, hopefully HS is sort of on your radar already, just with the phrase, painful abscess in armpit. Hopefully that's already sort of a flag for you. And I think questions to ask would be like, does she get it anywhere else? Could like posterior neck, or maybe the posterior thigh, under the breast. So other areas to ask about. Is there a family history of anybody else having similar lesions come up? What has she tried for this? Does it get worse with her period? Other things to ask include like impact on quality of life, what sort of comorbidity she may have. But certainly, with this clinical history, a biopsy would not be needed to make this clinical diagnosis of HS. She absolutely qualifies. You see that yellow Post-it there talking about key diagnostic features of HS. We're looking for typical lesions, inflamed nodules or abscesses or tunnels, or even open comedones. She obviously has nodules and abscesses going on. Typical locations, which we talk about, the intertriginous areas in HS does most commonly occur in the axillary and groin region. However, a note should be made that it can occur elsewhere on the body as well. I have patients with HS behind the ears, on the neck, on the chest, on the thighs. And so just because it's not in an intertriginous area does not mean it's not HS. And then the hallmark feature, I think, of HS is that chronicity. It's so recurrent, and that is what really separates it from some of the other things that may be on your differential diagnosis, which we'll talk about. So just remembering, it's a clinical diagnosis. Look for basically patients who are telling you that they're getting these recurrent bumps, recurrent boils or abscesses, and that should really sort of raise your radar for, could this be HS? There is a early staging diagnosis that's a quick and easy way to sort of stage how advanced the disease is in terms of tissue destruction. And so it's important to point out that this was really designed as a surgery staging system, so it's not appropriate to use this to measure sort of medical therapy response. But the way to do this is basically for stage 1, we see the nodules, we see the abscesses, but there are no tunnels or scars, so no irreversible tissue damage yet. In stage 2, you can get tunnels and or scars, but there's still normal skin between lesions in an anatomic region. Early stage 3 is when within an anatomic region, you basically have diffuse involvement, multiple interconnected tunnels, scarring, and there's barely any sort of normal skin in that anatomic region anymore. And if you look at this photo of early stage 3, looking at that, I know that if I give my medical therapeutic management, I'll be able to improve the patient's, hopefully, drainage, pain, but with all those sort of thick scars, the tunnels that have formed, that really will require surgery, to help reduce that tissue burden there of disease. And so ideally, we're catching patients in early stage 1 where we can maybe even prevent them from getting to such an advanced sort of tissue destructed state where they will need surgery to really reduce that disease burden. So signs and symptoms of HS, we talked about things to inquire about. Another thing there is smoking status, which you can ask about, and with comorbidities, specifically looking at other comorbidities that may be elevated in patients with HS, including Crohn's or ulcerative colitis, psoriasis, etc. And then that note on the bottom there to remind ourselves that HS can appear anywhere on the body that has hair follicles. So make sure your radar is up, even if it's not just in intertriginous areas. The key lesions there, abscesses or nodules, tunnels, purulent discharge, and non-inflammatory signs of disease are also important to notice spots. So open comedones or blackheads, you can get that double-headed comedone as well. And sometimes if a patient, for example, presents with just one abscess or one inflammatory nodule in an axilla, I'll look really carefully to see if there's signs of atrophic scarring or scars in that area. That would indicate to me that perhaps this is a recurrent issue that's happened for that patient, even though they're only presenting with one lesion, that this has happened before in the past. As stated earlier, HS is a clinical diagnosis, and typically, I think for derms, in terms of spotting HS, I think we're pretty good at trying to diagnose HS. It's the management portion, I think, that has been harder for us, just given the historical lack of, FDA-approved options. So at this point in time, when we see patients, I think one tricky thing can be when it's really early on HS, where patients may, for example, tell you that they just have one or two lesions. It's the first time they've ever gotten it. You might be in that state where you're like, is this folliculitis? So I think that chronicity and recurrence is key. And so if a patient really, it's like a first time episode where you're seeing them, I think it's important to basically watch and let them know warning signs for if the lesions continue to recur, then most likely it is HS. But otherwise, I think some things that can separate it from things on the early differential diagnosis list for HS, for example, like acne, we know that, again, with the sort of anatomic location where HS tends to occur, it's different from that of acne, which is really much more facial and truncal. And then if it's just one isolated epidermal inclusion cyst, for example, that ruptured, if you excise that, you get the cyst sac out, and that's it, then that would not, qualify that patient of having that chronicity and recurrence to having HS. And so I think that chronicity of disease. Recurrence of lesions can really be helpful in separating out HS and from some of these other sort of entities on that list. And then the other thing for late stage HS, this is really for patients who are presenting with tunnels. I would say HS really does look kind of classic morphologically when you have abscesses, nodules, tunnels, and a background of comedones. But if, let's say, you're treating a patient for HS and they're just not responding the way that you think a patient with HS would, like you start a medication and there's just no response whatsoever, or it's just worsening, you could consider making sure that it's not an infectious entity mimicking HS. You could do tissue cultures, etc. But in general, I would say clinically, it's with the history, with the physical exam, we should be able to diagnose HS. And just having these things on the differential in our back of our minds is good if the patient's history or the patient's clinical course is not progressing the way that we would expect with HS. In terms of comorbidities, there's multiple comorbidities that patients with HS may have, including cardiovascular comorbidities, rheumatologic, inflammatory. There's hormonal ones like PCOS. I wanted to spend some time talking about the increased risk of depression and anxiety with our patients with HS. Patients with HS really struggle with this. I think the mental health component really also affects their ability to, for example, even follow the treatment recommendations we may have if they're feeling so down that they just don't have the energy, to do something every day. And so in my clinic, I screen all patients with HS with the Patient Health Questionnaire 2 or the PHQ-2. It is free online. It is a 2-item questionnaire where you're basically asking patients to rate how frequently they might be feeling down or have lost interest in their activities. It's scored 0 to 6, and anybody who scores 3 or higher, it means that they're at risk of having a diagnosis of depression. And when that happens, I'll have the patient go back to their primary care doctor with a note to screen further. I will put in that referral to behavioral health, and I'll also provide patients with mental health resources, including connecting patients with support groups for HS, which oftentimes can help patients feel a lot less alone. And then other skin conditions that patients may have, these are just things that we as derms would screen for: psoriasis, pyoderma gangrenosum, acne, etc. So moving past diagnosis and on to sort of what has the patient encountered up until the time that they see us. So the patient journey. So HS, we really should be focusing on it not as a rare or orphan disease, but one that is common. The prevalence globally is 0.1 to 4%, depending on population and methodology used. I would say that in the US, we're thinking it's probably close to about 1%, which would be 1 in 100 people, certainly not rare. It is twice as common in women versus men, and in the US, the prevalence in Black patients may be 3 times higher than in white patients. It frequently occurs after puberty, but can occur in a bimodal distribution where sometimes patients will come with their first lesion having occurred in their 40s. Risk factors for HS include smoking, obesity, family history of HS. One important thing to note, though, is that HS should not be excluded on the differential just because a patient doesn't fit the demographic factors of these sort of at-risk populations. So I've many patients who, for example, they may be underweight or a male patient. And I think that one really important thing to remember is that HS can affect anybody from any background. And this will help us make sure that we don't miss the diagnosis of HS just because it's not fitting the category of demographics that, we are trained to think that it occurs most commonly in. The burden of HS is very high. We have multiple patient surveys that have been out asking patients about quality of life impairment. And every time when we do this, we see that the burden of HS in terms of quality of life impairment is one of the highest for HS compared to other dermatologic diseases. There's a lot of pain, embarrassment, social stigma. Patients oftentimes blame themselves for their condition. There's discharge or staining of clothing that can, again, lead to further embarrassment, the scarring that can occur, negative impact on, friendships, but not just that, also intimate relationships or the ability to have one, and then depression, which we talked about. And We have seen studies showing that quality of life impact can correlate with disease severity, like increasing number of lesions, also certain locations being affected, like the groin area or the gluteal area. But it is important to note that patients still who are, sort of maybe earlier in their disease stage, they can still have a very large quality of life impairment. It's not just patients with early stage 3 advanced disease who may be having this quality of life impairment. So that's important to note. We can't talk about HS without talking about flares, as flares is one of the major things that can impact a patient's quality of life. Patients have a lot of anticipatory anxiety about flares. They might have an event planned and then an HS flare can happen, and then now they can't attend this event. And so anxiety around flares and being nervous that they'll have a flare and they won't be able to access the care they need, I think is a huge component of what can impact quality of life. Currently, there's no uniform definition of flare. Clinical trials define flare as a 25% increase in abscess and inflammatory nodule count, with a minimum increase of 2 abscesses and inflammatory nodules relative to baseline. However, I think when we ask patients about flares, it could be very different. So if a patient, let's say, has 6 inflammatory nodules, but then they get one large abscess on their gluteal area, they can't sit, they can't walk, even though that wouldn't meet the clinical trial definition of flare, that patient will most likely tell you that their HS is flaring. And so really this definition should include both patient and clinician report of changes. It's been shown that more than 80% of patients experience flares and exacerbations at least monthly. Really debilitating, it's unpredictable. And one thing that I use to help counsel patients about how to sort of track if their treatment is helpful is I'll tell them, when we start a therapy, I'm really looking to see too, if you get HS lesions, are the HS lesions smaller? Do they happen less frequently? Do they last for a shorter amount of time? And so flare frequency, severity, and duration can help inform treatment efficacy and also help patients understand what to look for in terms of whether or not treatments are working. So discussing treatment goals with patients, we want pain to decrease, drainage to decrease, control their flares, prevent worsening of disease. Setting realistic expectations is super helpful because we don't want patients to start medications and expect that all of their HS tunnels will disappear, for example. And so there is no cure at this point in time, but we can absolutely help patients feel better and help them get to a point where hopefully their HS is not always on their mind and it's not impacting their ability to live the life the way they want to live it. So many therapies currently directed at the inflammatory component of disease, but procedures may be needed for fixed and persistent lesions. Change might be gradual, so patients should know that when we start medications, we want them to be on the medication for at least 3 to 4 months so we can give the medications a chance to work before prematurely moving on. Many of the patients may also be interested in holistic care, and so I think remembering that we have other care partners we can refer to is important as well. And in terms of this diagnosing HS early, which ties us back to that, HS diagnosis, it really makes a difference for patients because the longer they wait, the more severe their disease is by the time they come to see you. That means the more the patient has suffered up until they've seen us. And by that time, too, many patients have had surgery before they even step foot to see us. And so being able to diagnose earlier and using that window of opportunity where the patients don't have extensive tissue damage and we can start these medications that are meant to try to help prevent HS from progressing to later stages with irreversible tissue damage and, kind of reduce the amount of overall disease burden on their mental health, on their emotional well-being, and also just physically, the marks left on their bodies would be really great. And I think that that's why as a community, really pushing for also education of those frontline providers who are seeing these patients in the ER, in urgent care, in primary care, in pediatric offices to have HS on their radar. If you see it, refer to derm. Let's get them plugged in with good long-term therapeutic options so that we can help these patients not progress and have, really undue suffering. So, to wrap up this section, clinical pearls for diagnosis, HS is a chronic inflammatory skin disorder. It's really important to educate about that and let patients know it's not infectious and also that it's not their fault. They didn't do anything to bring on HS, just like patients with eczema and psoriasis didn't do anything to cause their eczema or psoriasis. It can just happen and it's not their fault. Location and chronicity are key to diagnosis, but remembering that, it can occur outside those quote unquote typical intertriginous locations. HS, at this point in time, we feel it begins with obstruction of hair follicles. There's rupture and subsequent inflammatory reaction. Though there's also research going into, why obstruction of hair follicles. Is it a dysregulated immune system or dysregulated inflammation that basically predisposes to some of this obstruction of the hair follicles in the first place? And then the development of HS appears to have both hereditary and environmental influences. We talked about that significant psychosocial distress and how the best prognosis really involves catching this early, diagnosing this early, and then initiating timely, appropriate treatment at the earlier stages. All right, so now we're going to shift gears and focus on HS management. And the hope is really after this section, you'll be able to go back to your clinic and the next patient with HS who you see, you'll feel like you have more tips and tricks in your treatment arsenal to be able to help optimize their care. We'll start again by revisiting Jill, our 32-year-old woman who, appears to have sort of this earlier stage HS, right? Although we're only seeing one photo here. We don't know what the other areas of her body look like, but presuming it looks about like this, she's either early stage 1 or if she has scarring, perhaps early stage 2. At this point in time, like when I see a patient for the first time, I'd probably be thinking like, okay, are there hormonal or metabolic therapies I can try? Talk about topicals, thinking about other elements like with laser hair removal maybe work. So these are the types of therapies that we'll be talking about for our patients with milder disease. Frank is a 29-year-old man that we'll talk about as well as our second case study. He clearly has HS early stage 3, so advanced tissue destruction we can see with those interconnected tunnels on his left inner thigh. At this point in time, when I see a patient like this, the top 3 things I'm thinking about are, number 1, I'd want to think about starting a biologic as the sort of cornerstone of his medical management plan. And then think also about adjunct therapy, so likely an antibiotic that I'd want to start just to help, especially if he's coming in with a lot of pain and drainage, just to help try to calm that down more quickly. And then also thinking about him likely needing surgery down the line. So those would be sort of the top 3 things I'd be thinking about while trying to optimize other parts of his care as well. And then, I think one important thing here is when I see a patient like this, I'm always also thinking like, I wish I saw this patient earlier, maybe, 10 years ago or 20 years ago or whenever this started. My hope is we see fewer patients with this advanced disease in our clinics and we can see more patients at the earlier stages. So the 2019 North American HS management guidelines are actually very outdated. For example, at that time, the IL-17 agents that we have, secukinumab and bimekizumab, which are both FDA approved at this point in time, they're not on the North American algorithm because it wasn't approved at that point in time yet. And so here is an algorithm or an updated one that I worked on with fellow HS experts just to try to help update the treatment arsenal for practicing clinicians since the 2019 guidelines were published. And so hopefully this will be a useful reference and we'll be touching upon, points from this algorithm through this talk as well. So in terms of management for milder HS, which, I touched upon when, looking at Jill's case earlier, there's lifestyle modification that you'll talk to patients about, if they're smokers, smoking cessation, weight reduction. One key point is really not to start your conversation or start your first visit discussing lifestyle modifications. So many patients with HS have already heard that they just need to quit smoking or lose weight and their HS is going to, improve drastically. And honestly, I have many patients who are non-smokers or again, they're underweight and their HS is just not doing well. And so I think this is part of our overall counseling just for their, overall health benefits as well, but really I would dive into those topics after you've established rapport with the patient. It can be, not at that first visit. Topical therapies that can be tried include antiseptic washes like Hibiclens, benzoyl peroxide, Sealant wash, clindamycin 1% topical. Resorcinol is another topical that can be tried. Systemic antibiotics, there's several, so tetracyclines. I also use Keflex or Augmentin, Bactrim. And so there's several antibiotics that you can use for monotherapy for milder HS, but remembering that the role of antibiotics is not as a long-term therapeutic option for HS, whether milder or more advanced. The role of antibiotics we should really think of as PRN for flare, maybe for 1 to 2 weeks, or as a 3-month bridge to sort of help the patient feel better while your long-term therapeutics are kicking in. And so hopefully we can, as we have these more therapeutic options that are efficacious and more appropriate for long-term use, we're able to sort of reduce the role that antibiotics play for HS care. Zinc gluconate for those patients who want sort of natural ways to approach HS. There are studies showing that zinc gluconate may be helpful, and you can have patients take it in about a 10-to-1 ratio to make sure that they're not copper deficient, because zinc and copper can compete for absorption. Oral retinoids have mixed data in the literature. Sometimes they can actually flare HS as well, so you need to definitely start low and go slow with the oral retinoids. Acitretin actually has superior data over isotretinoin, but for our females of childbearing age, it, I think, would be a very difficult medication to start and isn't really an option. And so just being aware of the limitations of oral retinoids is useful. Hormonal therapies can be very helpful for patients with HS, so spironolactone, an oral contraceptive that has an anti-androgenic progestin, such as drospirenone, and finasteride. And metabolic modulators can be helpful as well, like metformin or GLP-1 agonists even. GLP-1 agonists is a hot topic in dermatology, especially I think in HS too. We can see how with the metabolic dysfunction of HS, and then also, the fact that there are patients who are also seeking to try to have weight loss. GLP-1 agonists may be helpful in 2 ways to help with weight loss and also potentially with its anti-inflammatory benefits for HS. But more studies need to be done because most of the studies right now are case series or case reports, many patients on concomitant HS therapies. So it'd be great to see some randomized controlled studies with GLP-1 agonists. And then procedural interventions include laser hair removal, botulinum toxin injections, deroofing excision of fixed HS lesions. Let's say a patient keeps getting an inflamed nodule sort of in that same area. We talked about the non-medical interventions for all patients with HS here. One quick thing I'll note about pain management is that a cornerstone of treating HS-related pain is anti-inflammatory therapy targeted at the disease. So making sure we get that inflammation well controlled can significantly help HS-related pain in many patients. However, some may still have pain that's chronic despite getting that HS, inflammation under better control. So acetaminophen, NSAIDs, and also other medications may be tried, including, for example, gabapentin, pregabalin, or duloxetine. And then if the pain simply is not something that, you're able to manage despite best efforts, referral to pain management may be helpful as well. And then finally, another reminder to make sure to refer to other potential members of the care team to help, especially with comorbidities. I think it's very helpful to have a primary care provider on board with you to help screen for the multiple comorbidities and help with management of those comorbidities for our patients with HS. So back to Jill, we talked about things that we would consider. And I think that one point I wanted to make here is, let's say you do start the patient on hormonal and metabolic therapies and some topicals, and maybe she opts for laser hair removal. However, she continues to have recurrent inflammatory nodules and abscesses, and it's impacting her quality of life. We know at this point that, our biologic agents are approved for moderate to severe disease. The question, I think, is really, how do you define moderate, right? How do you define moderate, and is this patient a candidate for biologic therapy? So if you look at different sort of measures of measuring HS severity, the Hidradenitis Suppurativa Physician Global Assessment Score, the HSPGA, on that scale, actually, all you need is one abscess and one inflammatory nodule to be classified as having moderate disease HS. I bring this up just to remind us that you don't need to have a patient with a lot of tunnels or a lot of scarring or multiple inflammatory nodules or abscesses to say, like, okay, you are now a biologic candidate, you have moderate disease. For our patients where you've tried, your metabolic hormonal modulation, you've done your best with, the non-biologic therapies, but they still have recalcitrant disease that's impacting their quality of life. I think at that point in time, it's time to introduce that idea of a biologic and knowing that we really shouldn't be saving our most efficacious therapies, for later down the line when there's a ton of tissue destruction. We want to start earlier, hopefully when the medication will also be more efficacious as well. So that brings us to management strategies for moderate to severe HS. And so, as I mentioned earlier, when I think about my patients with moderate to severe HS, I think about having a biologic as the cornerstone of my medical management therapeutic regimen. And so, bolded there are the 3 FDA-approved therapies that we have, which really helps with access. We have adalimumab, a TNF-alpha inhibitor, secukinumab, an IL-17A inhibitor, and bimekizumab, an IL-17A and F inhibitor. Systemic antibiotic-wise, I might consider combination antibiotic regimens. These may include Bactrim and Keflex, Cipro and Flagyl. I've moved away from using Clinda and rifampin together just because there's been studies showing that monotherapy clindamycin actually may be just as helpful as Clinda plus rifampin. And when you do Clinda and rifampin together, the levels of clindamycin are actually really low or almost undetectable. So that's just one thing of note because clindamycin and rifampin has a lot of data in the literature, but it might actually not be the best way to go. In terms of other systemic therapies, so besides the 3 FDA-approved therapies, we'll also talk about infliximab, which can be a very helpful medication. It's given IV. And then JAK inhibitors, PDE4 inhibitors, other biologics we'll touch on as well, but they just don't have the same degree of data that our, FDA-approved therapies do. And then in terms of procedural interventions, deroofings, wide local excisions, really within the wheelhouse of, derms. As long as we have a standard excision tray and, we can cut out basal cells and melanomas, we're able to help these patients out and cut out their HS tunnels. And we'll talk about that as well. All right, so let's revisit Frank, our 29-year-old man. I talked about the, considering that biologic, antibiotics potentially, and then also thinking about surgical procedures I'd want to do. And then when you'd consider starting a biologic agent, honestly, in this patient yesterday or maybe 10 years ago when, hopefully we could have caught him and diagnosed him earlier. But absolutely, I think it's something that you'd need to talk with the patient. And, it can still take time for patients to, understand that their condition is not infectious, that there's too much inflammation, and that you're starting a biologic in order to help reduce the overinflammation in their body. And I think that sometimes it won't be that first visit, when it happens because you're introducing new concepts. And but I do think that that's why establishing that rapport with patients is so important. It's so that when they are ready and when they have more questions or they have concerns, they're willing and open to talking about it with you. And we know that patients in general haven't been that satisfied with HS treatments. And, given that we've had a lack of, sort of FDA-approved therapies for so long, I can understand the frustration that these patients have felt. And on the flip side, the dermatologists have felt when trying to, just help their patients feel better. And so there was an international study, the Global Voice study, of over 1,400 patients where 45% were dissatisfied or very dissatisfied with their treatment. When the patients were on a biologic therapy or treated by a dermatologist, their satisfaction rates were improved. And then another study was done looking at asking patients about satisfaction of care and finding that less than 20% were satisfied or very satisfied. Only about 39% with more advanced HS were actually on biologics, and there's actually even larger studies showing that underutilization of biologics for HS, even amongst patients with advanced disease, definitely exists. And then that 74% were actually unaware of the FDA-approved HS treatments. And so I think that that really speaks to the importance of patient education as well, about HS, and that there are treatment options that are available, that are FDA approved, so that they know to ask about them. So our FDA-approved biologic therapies for HS, we have adalimumab, secukinumab, and bimekizumab. You can see here the mechanism of action for each, adalimumab being approved for 12 and up, secukinumab and bimekizumab approved for 18 and up. The route of administration for all three is sub-Q injections, and you can see the induction dose and maintenance dose written for these, where for maintenance dose for adalimumab, it's either 40 weekly or 80 every other week. For secukinumab, it's 300 Q4 weeks, and you can increase to 300 Q2 weeks if needed, so it's on label to do so if patients are candidates. And then bimekizumab is 320 milligrams every 4 weeks. Although I will say that off-label, I've also increased it to every 2 weeks. And one way that helps me decide if I think updosing may be useful is, let's say a patient is on secukinumab or bimekizumab, and they say that they do well after their injection, but sort of before their next injection, they start to feel like their HS starts to get more active or flare. I think it's helpful to give that dose every 2 weeks instead, to try to head off sort of that, a little bit of that waning effect before their every 4-week injection. So for adalimumab, it's the first FDA-approved therapy for HS. Basically, about 50% were able to achieve the Hidradenitis Suppurativa clinical response score in the trials, which I'll show you. Higher doses are needed in patients who have higher BMI, and we definitely do see that there can be reduced efficacy over time in some patients. Part of that likely due to the fact that you can get anti-drug antibodies with the TNF inhibitors, which can then make the medication sort of less useful for patients. Of note, I typically will use the 80 milligrams every 2-week dosing with adalimumab, and then I've also updosed to 80 milligrams weekly, and that could be a consideration for your patients as well. Here are the PIONEER studies, PIONEER 1 and 2 on the left side of the panel. It's basically a 12-week study where the primary endpoint was high score. High score, the Hidradenitis Suppurativa clinical response score, basically you achieve it if you have a 50% or greater reduction in your abscess and inflammatory nodule count at the week 12 primary endpoint, and no increase in your number of abscesses or draining tunnels compared to baseline. And you can see across the two studies, about 50% of patients on the 40 milligram adalimumab weekly dose was able to achieve this, compared to only 26 to 27% on placebo. And there were no new safety signals that came out of the PIONEER studies for HS for adalimumab. There was an open label extension study that went through week 168, so over 3 years. And what's seen there is basically that of the patients who stayed in the study, they still had over 52% of patients still achieving high score during this long-term adalimumab treatment. So let's go back to our patient, Frank. He was started on a 12-week course of adalimumab, and at this point in time, it could have been an adalimumab biosimilar. And he was given the 160 milligram sub-Q dose, followed basically by 80 milligrams every 2 weeks. But unfortunately, after 12 weeks, he came back and he didn't have significant improvement. He still had pain and drainage. And at that point in time, what steps would you take to adjust his therapy? And I think, it would depend on your conversation with Frank and how he's looking, whether you'd want to consider updosing to 80 weekly, or at that point in time, consider one of the other FDA-approved therapies, which are the IL-17 inhibitors. An important point to make is that in that case with Frank, you could have also started with the IL-17 inhibitor, because adalimumab, secukinumab, and bimekizumab, all three are appropriate first-line options for patients with HS. In this case, the patient was started on adalimumab, and now you're thinking about switching, but it could totally have been that you chose an IL-17 inhibitor, and vice versa. So secukinumab is an IL-17A inhibitor. And it's approved, FDA approved for multiple indications, but it received its HS indication in October 2023. So it's really exciting. It was the second FDA approved therapy, and there had been a gap of basically about 8 years since adalimumab. Here are the phase 3 trials. In this case, the primary endpoint was measured at week 16. It's the same endpoint of high score 50. So you're, again, looking for that 50% improvement. And so in both studies, Sunshine and Sunrise, the two parallel phase 3 trials, there was greater response rates for secukinumab compared to placebo at all time points. Rapid onset of action by week 12, and then the continued superiority seen through week 16. And the clinical response to secukinumab also showed sustained and continued improvement up to week 52, and there were no new safety signals that were seen with secukinumab. So here's the data out through 52 weeks. You can see that after week 16, placebo patients were switched to secukinumab, and you can see that they have improvement in response. They catch up to the people who were on secukinumab from the start. And then you can see the nice line showing sustained and continued improvement out through week 52. And again, there were no new safety signals out through week 52 either. For bimekizumab, this is an IL-17A and F inhibitor, and it's FDA approved, again, for multiple different conditions, but for HS, it was approved November of 2024. Bimekizumab had phase 3 trials. Again, this was out through week 16, and the BHERD-1 and BHERD-2 studies were parallel phase 3 studies looking at bimekizumab 320 milligrams every 2 weeks or every 4 weeks up through week 16 versus placebo. And you can see, again, it's high score 50 at week 16 that we're looking at. These graphs are depicting a rigorous analysis where basically any patient who was exposed to any antibiotic, even, for example, if they got Bactrim for a UTI, they were automatically counted as a non-responder in the trial. So what we can see here is significant improvement achieved in terms of proportion of patients who were able to get high score compared to placebo patients if they were on drug. And so bimekizumab did lead to early and sustained reductions in abscess count, inflammatory nodules, draining tunnels, and skin pain. And there was also clinically meaningful quality of life improvements observed as early as week 2. Data is out through 48 weeks here, and here we're looking at observed case analysis. And you can see the patients who are on placebo now receiving bimekizumab who also have that improvement and are joining their counterparts who are on drug from the beginning. And we're seeing this nice sustained improvement out through 48 weeks. There were no new safety signals for bimekizumab versus the established safety profile of bimekizumab. In terms of safety considerations for IL-17 approved agents at 16 weeks, we can see here for secukinumab and bimekizumab, comparing some of the adverse events, there were higher rates of candida infections in bimekizumab patients in the bimekizumab trials compared to secukinumab. However, it's important to note that cases of candida in both trials, the majority are mild to moderate in terms of severity, and patients were able to treat through. So you can give the patients diflucan, clotrimazole troches, or nystatin swish and spit. And in general, patients oftentimes treat through. They're able to continue the medication. There's not a need to discontinue, but anticipatory guidance could be helpful. And in general, the IL-17 safety profile for our patients with HS in terms of discussing safety profile is fairly easy to talk about just because these medications have good safety profiles. So I definitely feel grateful that we have this class of medications that's approved for our patients with HS. Infliximab is another TNF-alpha inhibitor that's used off-label for HS. It's given as an IV infusion. And I am really glad that, we have a chance to talk about it because I've seen really good results for patients who maybe were recalcitrant to many therapies. And really, we have the benefit with infliximab of being able to do weight-based dosing. And so you can see here, this is a meta-analysis that my team and I put together trying to basically help look at cases across the literature. It was published in 2022, so it was cases before then, and looking at response rates, so any sort of partial response, although, of course, it was measured in different ways in different studies. And overall, we did see a pooled response rate to infliximab of 83%. And I'm hoping that references like this can help us get access to infliximab from insurance. And in terms of adverse events, it was in line with what we would expect with infliximab. So certainly a consideration. And I know that in derm, we don't do so much in terms of infusions. We typically do, sub-Q injections or pills. And so one option could be to consider partnering with a rheumatology colleague where they do infusions all the time. And so the infrastructure to get a patient infliximab may be easier. And it hopefully would be an easy visit for them too, just to help you start infliximab for your patient. In terms of dosing for infliximab, there was a study that found that infliximab 10 mg per kg every 6 or 8 weeks may be a reasonable dosage for patients with HS. I typically try to fight for 10 milligrams per kilogram every 4 weeks, but again, it'll depend on what insurance will allow. And then other biologic therapies for HS, just to quickly touch upon, IL-12/23 inhibitor ustekinumab has had small studies supporting its use. If you're going to use ustekinumab, try to aim for higher dosing. So I'll have patients that I try to get 90 milligrams every 4 weeks dosing. IL-23 inhibitors, so guselkumab and risankizumab, both had phase 2 trials that unfortunately did not meet primary endpoint. But I still will use IL-23 inhibitors as adjunct therapy, especially if there's, for example, a comorbidity that I can leverage for use as well. And then IL-1 inhibitor, so anakinra, there's been some small trials and small studies. But again, the data for anakinra is just not as rigorous as it is for the other medications that we had talked about earlier. For surgery, I think for patients who have fixed lesions, it's just an important part of HS care where we can optimize medical management and then also help reduce their HS tissue burden. And so for those persistent fixed lesions, oftentimes doing a deroofing or an excision on it can be incredibly helpful to turn it from an active spot or a recurrent spot into a quiet scar. There's a very high patient satisfaction rates from deroofing and excisions. It can be done using a standard excision tray. Your goal really is just to remove, that tunnel or remove that persistent HS tissue from that area. And the benefit of deroofing and excisions is that you can leave these lesions open to heal by secondary intention. So in the clinic, you're saving time on suturing, and you can basically maybe use a little extra time to make sure that you're numbing the patient really well, so that basically they have adequate pain control before you start your deroofing or excision procedure. And then there was a really important study that was done with adalimumab, basically, and surgery, basically showing that patients who had adalimumab while undergoing HS excisions or deroofings, they basically had no increased risk of post-op wound infection, complication, or hemorrhage compared to patients who were on placebo. And I think that's a really important message, not just for, us, but also for surgeons who may be treating these patients to not stop a biologic for your HS procedure. Because actually, I also think in terms of outcome, if you have a patient now who's super flaring off their biologic, I could see how that could impact wound healing, for example. And then in terms of, sort of looking at the future, so there's some phase 2 data on small molecule therapies in HS. Upadacitinib had positive phase 2 study in HS and is now in active phase 3. PD4 and E4 inhibition, so apremilast had an open label study in mild to moderate HS, but again, it was a small study, so certainly we need more data to be able to know what kind of efficacy we can expect to see from PD4 inhibition and perhaps the sort of best patient subpopulations to try it in. So in really exciting news, povorcitinib, a JAK1 inhibitor, had positive phase 3 trial results that were just announced earlier this year. And so hopefully we'll be able to have access to a JAK inhibitor soon, that's FDA approved. And so in terms of their trials, they had the Stop HS1 and Stop HS2 trials. Primary endpoint was HiSCR 50 at week 12. And 45 milligrams and 75 milligrams of povorcitinib compared against placebo and found to be superior in terms of ability to hit that HiSCR 50 at week 12. So hopefully, this is exciting because it would be a altogether different mechanism of action with a JAK inhibitor, but also a different mechanism to take the medicine, right? It would be the first oral medication that patients have that's FDA approved. So, to kind of summarize, talking about biologic agents and HS management, just remembering that when you're choosing a biologic agent, you also still want to think about adjunct therapies and how to combine with surgery as part of your multimodal management. There are options for dose escalation before switching. We talked about adalimumab and secukinumab and bimekizumab, what dose escalation could look like. When we talk about these medications with patients, I think it's important to remind patients that, you know, untreated HS can also have really devastating consequences with that unchecked inflammation and also just that terrible hit on quality of life that the patients are experiencing on a day-to-day basis. And so, yes, we talk about, safety profiles of our medications, but also thinking about, what does untreated HS look like? And then some questions to ponder. Would managing comorbidities help manage HS? Would managing HS help with comorbidities? And I think, it's really helpful to know our patient's comorbidities because it could be that you're choosing a medication that can help with both. Like if a patient has psoriasis and HS and you can start a biologic that helps with both conditions, that's really helpful. And then also there has been some studies that have now been done showing that, if we're treating our patients with HS with a biologic agent, for example, could we also help reduce the cardiovascular risk that they have, for example? And so, could we help sort of, potentially reduce their risk for inflammatory arthritis? And I think that these are questions that hopefully with large data sets we'll be able to gain more and more insight into because certainly with the inflammation that HS brings, it's not surprising that there's so many comorbidities that these patients have, and can reducing that inflammatory burden not only help HS, but help their comorbidities and potentially help with their, mental health comorbidities as well, with depression, etc. There are emerging HS therapies in phase 3 trials currently, and it's, I think, a really exciting time for HS because we do have a robust pipeline, and I'm just really grateful because so many of these patients, they've deserved better for so long, and I'm grateful for the medications that we currently have that are FDA approved. I'm grateful that there's investment going into treatments for the future for our patients. And you can see here we have BTK inhibitors. We talked about JAK inhibitors. There's also that topical ruxolitinib study, which would, is in phase 3 and would potentially be the first topical approved for HS. IL-1 inhibitor, IL-1, this one, lutikizumab, is an IL-1 alpha and beta inhibitor that had, and all of these studies having had positive phase 2 results. And then sonelokimab is an IL-17A and F inhibitor that's completing its phase 3 studies. So really exciting time in terms of, I think, being able to feel like we have hope on the horizon to be able to get really good control of our patients with HS. So in conclusion, when we think about HS, remembering that it's characterized by painful recurrent lesions that are most common in intertriginous areas but may occur elsewhere on the body. Misdiagnosis is common, but remembering a biopsy is not needed to diagnose HS. I think it's just having it on our radar and also educating our frontline providers as well so that they can refer these patients to us sooner. We know that it severely impacts quality of life and can be very, very, very devastating for patients. But that with these new treatment options that we have, the last 10 years, I think really having been revolutionary for HS in terms of finally getting FDA-approved therapies. We have biologics, small molecule therapies in the pipeline. There's also procedural therapies that are being investigated. And I really think that this offers new hope for our HS patient community and for us as clinicians who treat these patients to be able to offer comprehensive, optimal care that hopefully helps patients feeling better and getting back to being able to do the things that they want to do in life without HS being something that stops them every step of the way. So thank you so much for your attention. And I hope that this was helpful and will provide some pearls for you to take back to clinic when you see your next patient with HS. Thank you so much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by Purdue University College of Pharmacy. This accredited activity has been developed in collaboration with our educational partner, PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. To access all materials for this activity, visit peerview.com/TZU860.